I guess I better start. Do I have a disclosure slide here? Make sure I do. I don't. Okay, so I better disclose that I have no conflicts of interest. Our objectives here for this, the next 15 minutes or so, I want to contrast some of the traditional views of exercise and manual therapy with some perhaps possible more current alternatives. Now, I will say up front, this gets to be a bit more of a theoretical discussion. I get to sort of riff on ideas here. This isn't a lot of my own personal research area. My research area tends to focus more on the transition from acute to chronic pain, in particular in conditions like whiplash and low back pain. But from a clinical standpoint, I am what many would consider a manual therapist, in that I've gone through several years of postgraduate training to achieve a sort of higher level of expertise with manual manipulative therapy. There's a bit of a tension there for me, in that as someone who really has focused more on a biopsychosocial approach to pain management, the traditional biomechanical, structural, pathological understanding that's often taught in many of these sort of manual therapy type courses didn't really jive with my sort of conceptualizations of how we should be treating pain, in particular more chronic problems. I think the structural approach probably works better for acute related problems, sports type problems, that kind of thing, but not quite so much for chronic problems. Since that time, since I've completed my PhD and started a faculty position at Western, my role is to primarily teach in our postgraduate education system for advanced manual manipulative therapy. And I myself have had to sort of resolve some of the conflicts that I hold internally around the potential mechanisms of what we're really doing when we're putting our hands on people. And so what I'm going to do today is just walk you through some of really my own understandings of some of the mechanisms or potential mechanisms through which we might actually influence people's well-being through manual therapy. So from a traditional view, this is sort of what I would have learned really in physiotherapy school back in the 90s. We've got chronic pain, which leads to sort of disuse and atrophy of muscles, stiffness of sort of the passive tissues around the joints, immobility, and therefore more pain and disability. Vis-a-vis, the treatment then would be to mobilize things that are stiff, stretch what's tight, strengthen what's weak. And in that sort of traditional view, that should then lead to resolution of the pain and disability. But that was very quickly a rather unsatisfying understanding of physiotherapy and what I could best do for my patients. Evidence here supporting this, I think I don't need to tell the people in this audience that, by and large, the association between things like pain intensity and actual structural pathology is not as strong as perhaps we once might have thought. And in fact, the association between chronic pain and joint mobility is equivocal at best. In fact, there's really very little good evidence that a stiff joint leads to chronic pain. As examples of this, we look at this study here. The intention here was to evaluate the cognitive behavioral model of chronic pain development, which, for those who are unfamiliar with that, suggests essentially that having pain leads, in some people, will lead to sort of catastrophic beliefs about pain, fear avoidance, hypervigilance, disuse, disability, and therefore more pain. And in fact, Johan Vlaien, who's one of the authors on this paper, actually sort of developed that model initially. So in an effort to try and test that model, what they did was took 124 subjects in the subacute phase of low back pain and followed them for a year. And followed a number of indicators of physical activity. So they had an accelerometer strapped to these people for sort of 1-week periods and asked them to evaluate how much they moved around. At the end of a year, really, they didn't find any evidence that, in fact, this disuse and atrophy really occurred. So physical activity level really didn't change that much. And really, that's kind of the pinnacle of this cognitive behavioral model of chronic pain development. And the evidence for that particular phase of it doesn't seem to be there. The catastrophizing element, the fear element, even the hypervigilance element, we've got some evidence for that. But this whole idea of disuse doesn't seem to be panning out. On the other hand, though, we don't want to sort of throw the baby out with the bathwater. I believe from my clinical practice that doing something with my hands has an effect. And fortunately, there is evidence to support that as well. So a large Cochrane review of manipulation and mobilization for mechanical neck disorders found that strong evidence of benefit favoring multimodal care, in this case mobilization and or manipulation plus exercise. So this approach of manual therapy and exercise seems to be effective. I think the question is, why is it effective? I think we need to keep in mind that if whether we're looking at this over here is the ICF, the International Classification of Functioning Disability and Health model of health and wellness, and over here is Melzak's neuromatrix model. Both suggest that the idea of body function and structure, or sort of the sensory discriminative element of pain, is a component of a patient's overall either pain experience based on neuromatrix or sort of health and well-being. But really, health and well-being, which is sort of indicated by this middle square, is influenced by not only the health condition, which is what we tend to focus on in the structural pathological model, but also environmental factors and personal factors. And I think if we don't consider at least those other factors, we're missing a large part of what it means to be healthy. So I'm just going to touch on a few sort of possible potential alternatives here for new paradigms as far as understanding manual and manipulative therapy. These are the things we're going to talk about, and we're going to talk about them in sequence here. So starting with this idea of repetitive or rhythmic movement. Now part of this is what we do when we perform manual therapy. When we ask a patient to perform exercise, maybe whether that be riding a bicycle, walking, rocking on a treadmill, or if I grab the person's joint and I sort of mobilize it just in a light manner, I'm performing, rhythmic activity. In the case, we're looking at 20 minutes of rhythmic gum chewing. So all they had to ask patients to do was to chew a piece of gum, and they kind of do it to a metronome at about a rate of 1 every 2 seconds. Okay, you get the idea. Interestingly, over a course of 20 minutes, through this rhythmic movement, now they've actually repeated this with both walking and breathing as well, rhythmic walking and rhythmic breathing, suppression of a nociceptive withdrawal reflex, which is the magnitude of stimulation it requires before you sort of withdraw your limb. So that suppresses, so in other words, the sort of actual pain behaviors have decreased. But they've also found that at the same time, this is paralleled by increases in circulating serotonin levels and activity in the ventral prefrontal cortex of the cerebrum. So there's actually sort of a physiologic correlate here. The idea being that rhythmic movement increases serotonin activity. The authors then suggest that improves descending noxious inhibitory control. And in fact, perhaps what we're doing through sort of this nice, light, rhythmic movement is influencing the actual the nervous system of the patient. And I think this is going to be sort of a common theme as I move through here, that we can't underestimate the fact that really we're dealing with nervous systems more than anything else. What about this idea of exposure to a potentially feared activity and therefore reducing fear? Now, we've heard over the course of the Congress here that certainly fear is one of those sort of key major players in the experience of chronic pain and disability. It seems to sort of make sense that at least exercise, if not manual therapy, perhaps functions as a bit of an exposure to a feared activity. And if we do that carefully, perhaps the mechanism through which people are improving is actually reduction of fear. And so there's some evidence to support this, Liu et al. Doing a randomized controlled trial of exposure versus graded activity. Now the difference here is that in the exposure group, they actually have patients tell them specifically what activities they are fearful of doing. And this is usually through a series of photographs. And the patients choose the photographs that indicate the most feared things, most feared activities. And they then create a graded exposure program where, okay, so you're telling me that vacuuming is something that you've avoided doing because you're fearful it's going to hurt. And they say, okay, well, vacuuming requires this movement and maybe bending forward a little bit and sort of moving your legs around. Let's practice those individual components. And then as you can do the small components well, then let's put them together. And we sort of more closely approximate the activity that it is you want to do. And it's the same way that someone might treat a fear of flying or a fear of spiders, something like that. Graded activity, on the other hand, is a bit more of a regimented program, and it's largely sort of starting with light exercise, moving through to things like resisted exercise and aerobic exercise. Both groups improved significantly. Perhaps not surprisingly, there was a greater improvement in this idea of catastrophizing in the people who had the graded exposure. So those who were actually exposed to their feared movement improved better. Now I show you this. This is taken from the same group a couple of years earlier. Katja Boersma was the lead author on this one. This was a series of 6 case studies where what they did here was, again, they took people that started off fairly high as far as, now this case this was pain, but all of these people were high catastrophizers, highly fear avoidant, and put them through this graded exposure intervention. And you can see, I mean, in some, it's a dramatic improvement. They're certainly not all quite that dramatic. Some are a little bit more gradual. But this idea that through this process of graded exposure to a feared activity, people seem to improve, in this case at least, from a pain standpoint. So again, it may be that what we're doing with our exercise or our manual therapies is, in fact, whether we realize it or not, doing some sort of a form of exposure therapy. What about tactile input? I don't think we can underestimate the effect of actually putting our hands on people. Now, this particular study just came out at the end of 2010. What they did here was used a group of mice and exposed them to different tactile stimuli. Now, if you take a mouse and you completely remove tactile stimuli, what they found is that the nerves in the dorsal horn of the gray matter of the spinal cord, tended to atrophy. On the other hand, if they expose these mice to novel tactile environments, in this case it was things like sandpaper or little brushes and things like that, there's much better differentiation of nerves in the spinal cord and maturation of these nerves. Again, one wonders, what is the effect of putting our hands on someone now? Now, I realize I'm extrapolating animal research through to humans, so again, this is highly theoretical. But as far as sort of proposed mechanisms, this is sort of an interesting approach. We see here, this is taken from that paper, that in the control group, these little white arrows are just showing differentiated tactile cells in the dorsal horn. And when you get these mice who have actually been exposed to these novel tactile stimuli, the proliferation of nerves in that horn appears to have improved. And I think there's a poster actually next door showing the decrease in gray matter volume in patients with fibromyalgia. So perhaps the idea of improving gray matter volume is not that bad an idea. So what's the connection here? Why does that matter? I'm going to again borrow from Dr. Mosley, as Neil did earlier. He took people with chronic low back pain. And what he asked them to do, this was a small study, 6 people, but he asked them to complete a line drawing that had the back part taken out of it. And he said, I want you to complete this drawing based on how you sense your back. What we've got here are the results from the 6 subjects. Now, what they were given was essentially the upper part of this line drawing and the lower part of this line drawing. They were asked to complete the back part. And interestingly, from a perceptual standpoint, it was as though they had this abnormal, altered sense of what their back was, where it was, how large it was, where it was in space compared to the rest of their body. He also measured 2-point discrimination in these levels all the way along the lumbar spine. And once again, you can see there's a pretty clear relationship between where these people had a hard time identifying their back and their actual 2-point discrimination, so their actual ability to discriminate between 2 points touching their skin. So I look at this and I start to take these things and try and put them together. By touching the back of someone with low back pain, is this perhaps not a novel stimuli to an area that this person has largely withdrawn from? So perhaps here's another new mechanism for the effects of manual therapy or exercise. The glorious placebo effect. I love this title. I think I borrowed this title actually from a textbook. I don't think we can neglect the fact that expectation, regardless of what intervention we're applying, influences outcome. And we see that whether the outcome is conservative manual therapy, whether the outcome is pharmaceuticals or surgery. That expectation to some degree influences the outcome. And we also have to appreciate that laying your hands on somebody is a powerful effect. But placebo doesn't necessarily mean useless. Really, this means that there's sort of a top-down attack on the pain, just as there is a bit of a bottom-up attack on, well, careful of saying pain, let's say nociception. And so perhaps through activating sort of more centrally driven systems, we're really kind of attacking this nociception from 2 sides, both top-down and bottom-up. Emotional regulation, we don't want to forget this as well. It appears as though exercise may attenuate symptoms of things like depression or anxiety, which, as we know, tend to occur concomitantly with chronic pain. nice touch, might ameliorate stress, depression, and anxiety. Now I'm going to say the strength of this evidence is not overly strong, but commonly exercise is prescribed as a reasonable approach to conservative treatment for depression and anxiety. Maybe that's one of the effects we're having. And finally, I'm going to finish off with the idea of somatosensory recalibration, as I'm going to call it. Neil, before me, showed a nice case study of a patient with chronic pain, did an fMRI scan, and saw different parts of the brain lighting up in the patient with chronic pain. They lit up in a sort of abnormal way compared to what we might expect. And this is being shown in other studies as well. I want to go through and use this slide to describe what it is that I want to get across here. This is a study that was done, again, this is a small study looking at 6 people with complex regional pain syndromes. This is a neuropathic syndrome of in this case it was the upper extremity, the hand. Here's what they did. They again used the functional MRI approach. On the far left, you'll see a spot of the somatosensory cortex lighting up in response to tactile stimulation of the finger. Now this is the healthy index finger, so if somebody's got CRPS, let's say on the left, this would be the right side. Okay, this is the healthy side, and this is sort of what you would expect. The stimulation was, as you can see, maybe mildly painful, a 1.5 sort of out of 10 on a pain-related scale. Oh, sorry, I'm sorry. No, it's 3 out of 10, or 2.5 out of 10. This is 2-point discrimination over here. Okay, so this is normal 2-point discrimination. In other words, the patient was able to identify 2 distinct points on their skin until it got within 1.5, I think it's 1.5 millimeters. Now they look and compare that to the side that has the complex regional pain syndrome. What we see here in the brain, in the fMRI studies, is that the representation of the finger is considerably smaller. Okay? Now they went over a course of, you can see here we start in May 24th, and then the next one is June 12th, and finishing off September the 5th. Okay, so a fairly long period from May through to September. They went through a process of essentially progressive sort of desensitization for this patient. So it started off with light tactile stimuli, worked through to more sort of motor involvement, so exercises, grip strength, range of motion, things like that. Now what I like about this is that we see improvements in both pain. So the yellow diamonds are pain intensity. The red bars are 2-point discrimination, and in both of those, a smaller value would be considered better. Okay, so for 2-point discrimination, this suggests you can identify things as they get closer and closer, and certainly pain intensity lower is better. And it's paralleled by increasing representation of the finger on the somatosensory cortex. Again, the question becomes, in our patients with chronic pain, could it be that at least part of the effect we're having by either putting our hands on their joints and mobilizing them or asking them to perform exercise may be in fact occurring as much up here as it is out in the periphery? That's not to say that I'm trying to say somehow pain is made up or psychosomatic or all in the head, but no, it's the brain that we're dealing with here. So what I think I see frequently are a lot of sort of RCTs comparing manual therapy to something like sham manual therapy, maybe manipulation to sham manipulation, acupuncture to sham acupuncture for that matter. A lot of things are compared active treatment to a sham version of the same treatment. I just showed a number of mechanisms here that would suggest the effect of manual therapy would occur regardless of whether or not it was an active or a so-called sham treatment. And so I think part of the way we need to maybe understand some of these things is that it's probably not as important that I know exactly what direction that facet joint needs to be glided, in order to get the therapeutic effect, but there are probably other multiple mechanisms that are occurring here. I think this kind of approach will facilitate the design of future studies. Maybe we need a better control condition than just sham version of the exact same thing we're doing. Because again, these mechanisms would suggest it doesn't matter what direction that joint's being moved. So I'm going to say in many cases, this is my take-home here, it probably doesn't matter which way our joint is moved, especially in the more chronic state. I think the biopsychosocial model suggests that therapeutic benefit can occur through a variety of mechanisms, and we don't want to forget that. And I would also say that new control conditions are necessary. And also I would say that the outcomes we're measuring probably need to be reevaluated as well. Is it just pain improvement that we should be measuring, or should we be looking more at things like quality of life, well-being, satisfaction, and things like that? I would suggest that perhaps we do need to go in that direction. So, I would just like to acknowledge the people who have invited me and sent me here today.